Hi guys, we are going to do a grand ward round. At this present, we are in discussion about patient who has presented with acute myocardial infarction anterior, proven on ECG. The patient has heart failure and the patient has also cardiogenic shock. We are now in discussion on how treat this patient and what are the monitorings that we need to do. So we will now go on. Okay. So we were talking about antiplatelets, and there's nothing that we don't know. All patients undergoing primary PCI should have dual antiplatelet therapy. Aspirin should be given orally, and should be given a loading dose of 300 milligrams stat, then about 150 milligram daily. You can go down to 75 milligram. Clopidogrel is highly effective, but it is a pro-drug. It takes a few hours to reach therapeutic level. And currently, I think the therapy of choice is actually a new generation of drug, which is P212, Y12 receptor inhibitor, is ticagrelor. And the Plateau study actually showed that ticagrelor is superior to Grel. And the duration of treatment is actually dual antiplatelet therapy for 12 months. Nizar, how about patients who do not go for angioplasty? They are just treated with thrombolytic. You still give them dual antiplatelet therapy?
No, I usually give them only aspirin, and then
You only
when they're planned for angioplasty after the thrombolysis, then I would give them dual antiplatelet.
I think there were enough studies to show that dual antiplatelet therapy is
For
better.
yeah, that's true.
So I'll look up for this the journal review to see this. Okay,
You know,
we go on.
there was a question about this patient's blood pressure is low, whether you should support it with the inotropes or not.
Yes, so it's part of our
With,
discussion later.
Mhm.
So we will answer that question later. So this thrombolytic fibrinolytic therapy, of course, there are some absolute contraindication to it. Previous intracranial hemorrhage or stroke of unknown origin at any time. I think if it's stroke, I think if it's more than 6 months, it's okay. So ischemic stroke in the last 6 months, central nervous system damage or neoplasm or AV, known AV malformation, recent trauma, surgery or head injury in the last 1 month, gastrointestinal bleeding within the past month, known bleeding disorders. Okay, menses is not bleeding disorder. And this one, I got it from the American Heart Journal, Heart Association guideline. Aortic dissection, non-compressible puncture in the past 24 hours. And then, of course, we have relative contraindication, that's TIA in the last 6 months, oral anticoagulant therapy, pregnancy, refractory hypertension, which doesn't apply here, advanced liver disease, infective endocarditis. Why cannot give thrombolytic in infective endocarditis? I never knew that.
You can get septic arthritis and you can bleed.
Really, active peptic ulcer disease, um, and then prolonged or traumatic resuscitation. So this patient has none of the above.
Which is
So
interesting.
this patient,
You brought this
yes,
up
go on.
when this patient has got hypertension, and you have to think if this is aortic dissection as well, because you can't give thrombolytic if the patient has got aortic dissection, right? Now, what's interesting
But
is
you seldom get presentation of aortic dissection without
except
high
that
blood pressure.
the thing about it is would be usually it's the right coronary artery that is
Yes.
that tends to dissect into, right? Secondly, you should try and hear for regurgitation murmur, as well as pericardial rub at the same time. That may give you a clue that this is dissecting aneurysm as well. And obviously, you must look at the pulses, the peripheral pulses, whether they're equal or not. So those are clues if the person presents with a inferior infarct, uh, and then has severe hypertension, and you hear a recent or a new regurgitation murmur or a pericardial rub, and the pulses are not equal, then you really have to think about dissecting aneurysm. You need an X-ray and an echo before you start thrombolytics as well.
But I tend to see, I've seen aortic dissection quite a few times, but they're not common. But always keep it behind the back of your mind. But they usually have very high blood pressure, and they don't usually present with cardiogenic shock.
They
Okay?
can, but they can, but
They
it's
can, huh?
unusual. Yeah, I've seen it. I've seen people presenting with anterior infarcts as well, but usually there are other clues to the dissecting aneurysm.
I had the patient with chest pain with inferior MI. They're a lady. And then I went on to do an angiogram, and my catheter was in the false loop. It was damn scary. I sent it to Dr. Azhar. Okay, hold on. Huh? So we go on. Okay, this primary angioplasty is the choice of treatment, a choice of reperfusion if the facility is available. It's best within 3 hours of onset of chest pain, but it can be done even up to 12 hours. But it should be done only if the door to balloon time is less than 90 minutes. So as you can see here, okay, this is the left anterior descending artery, and there is an abrupt, okay, closure of this artery, and this is what happens after the opening up. So, okay. Now, just now, okay, let's go through some of the questions that some people have asked. Okay, so we have answered whether we should resuscitate the patient. There's no need to resuscitate the patient because the patient is quite, is not in, there's no need to resuscitate the patient, basically. Okay, resuscitation means that when the patient has already had a cardiac arrest, blood pressure is not recordable, pulse is not palpable, patient is not conscious, then you start resuscitation. But in this case, the patient is conscious. Okay, there is blood pressure, low, but there is blood pressure. Okay, so so just now somebody asked, okay, so how do we treat? What medication do we use for hypotension? So cardiogenic shock in acute myocardial infarction complicates about 5 to 10% of patients with acute myocardial infarction. Okay, now this is seen more in women than in men. Okay. Higher risk of readmission within 10 days despite treatment for AMI when the patient presents with cardiogenic shock the first time round. The pathophysiology in this kind of cases would be because of diminished cardiac output, cardiac ischemia, vasoconstriction, and even inflammation. And acute kidney failure is seen in 15 to 30% of patients with cardiogenic shock. So now at this point of time, his creatinine that is high, okay, could be an acute kidney failure because of the low blood pressure. So it could be reversible. So how do we treat cardiogenic shock? Okay. Now, some people might want to give an intravenous fluid challenge, which I would seriously avoid in this patient. The lung is wet, okay? I would try to, at all costs, to avoid ventilation. So if you give intravenous fluid challenge in this gentleman, chances are he will get worse. Okay, and we would then go on to need to ventilate him. But Dr. Ahmad, Nizar has a point about using BiPAP. Nizar, maybe you'd like to tell them what BiPAP is and how it will help.
What we're introducing is actually positive airway pressure at the end of the tidal volume as well to keep the airway open. And the added pressure also keeps the fluids from entering to the alveoli, and therefore allow the patient to be better oxygenated, and he feels more comfortable as well. The only thing about positive air pressure is his blood pressure is low. So you might actually cause reduction in preload as well. That is the venous return, and his blood pressure may fall a little bit. So you will have to probably consider vasopressor support as well at the same time.
Yeah. You see, when we do this angioplasty, we need the patient to lie flat. Okay? And it is very difficult to do it if the patient can't lie flat, the patient is restless and in distress. Okay. So we need to make him as comfortable as possible before we actually get him. So how do we actually bring up the blood pressure? Okay. First, before we speak about that, I will go on to say that I would give the patient some Lasix, maybe a small dose, 20 to 40 milligram, push a little bit of fluid out and make him a little bit more comfortable. IV morphine we have mentioned, okay, it will help both the pain and also the fluid overload. Vasopressor support. We have a few choices. We have dobutamine, we have dopamine, and we have adrenaline. Now, I would start with dobutamine. Nizar?
I think it would be one of the choices, but it might cause the blood pressure or the systolic pressure to drop further, because it has got some beta 1 effect, isn't it? It causes some vasodilatation as well, which is
Okay.
actually something that you want in this situation, since this is a pump failure, a cardiogenic shock. There is usually reflex vasoconstriction, and it's actually detrimental in this situation. So there is a way of actually measuring cardiac output, dobutamine would be a good option actually.
Yeah. I think they have a vasodilatation and effect only at low doses. Especially in dopamine, some people give low doses as what a renal dose. Okay. So for example, in this case, if you want to bring up the blood pressure, I would say, let's say, put on dobutamine, and then if you need to add on, you add on the dopamine, and you add on a no add if necessary. But usually at the blood pressure of 80, 50, you revascularize, you wait for a while, the blood pressure would tend to come up in the next few days or so. But if you have put the patient on dobutamine and dopamine, and during the last bit of it, the blood pressure has come up, and you have tailed it down and taken off your dobutamine, sometimes you can put the patient on a low dose of dopamine just to, you know, encourage renal reperfusion. NOAC can be used, but the problem with using all these drugs is that increases the risk of tachyarrhythmias. Nizar?
Yeah, they do increase the risk for cardiac arrhythmias. Um, but I think the immediate issue here is trying to
Yes.
increase
Bring,
the mean arterial pressure actually.
yes. So
I aim
we have no choice.
to get the mean arterial pressure to maybe above 65. I'm not sure what his usual blood pressure is, it might be high because he's hypertensive. But
Yes.
in a normal person, I would actually target a mean arterial pressure above 65. And if I can achieve that with dobutamine, I'll be happy.
Yeah. But there are many devices that can actually help increase the cardiac output. They are called mechanical circulatory support devices, and that include an intra-aortic balloon pump and impaler. I usually tend to not use these devices unless absolutely necessary. They are very costly. Um, do we have enough clinical evidence to say that they help?
I think the
Recently,
intra-aortic balloon pump, the I mean, if you look at pathophysiology, it should work. There are reasons to use them because what an intra-arterial balloon pump does is it actually increases diastolic blood flow through the myocardium. It also reduces peripheral vascular resistance, and both are actually or benefit to a person with cardiogenic shock. The only issue is if this is not a reversible condition. If this is, then you will have difficulty because they will be dependent on the IABP actually. So, but usually when you do primary PCI, you insert the intra-aortic balloon pump. It is probably temporary. If you can actually open the vessel up, you probably will not need the IABP for long, and it might be
yes.
beneficial.
Okay, and I cannot emphasize more that in patients like this, frequent monitoring is extremely important. Okay? Sometimes in this kind of patients, I call up regularly, check on the blood pressure and the urine out. And sometimes I truly celebrate when there is a really good urine out. More so than the blood pressure, I'm always more worried about the urine output. Things turn around once the urine output comes out, and then you know your patient is going to get better. Do you get that feeling?
Yeah, obviously, because if the urine output is there, then cardiac output is improved as well, isn't it?
Yes, this is very important. Okay, we will answer the questions later. Okay, so now as we know, in this patient, he has not just acute myocardial infarction, he has cardiogenic shock, he's in heart failure, he has acute kidney failure. Okay, and we need to know we know he has multiple risk factors. How do we score them? We use a TIMI risk score. So he is young, so age older than 75 is 3 points. He's not even 65 and above. Okay, he has diabetes, he has hypertension, that's 1 point each. He had no history of angina. He has a systolic blood pressure of less than 100, so 3 points. Okay, heart rate is high, so 2 points. And then he is in KILIP 2, maybe even 3, right?
Could
Okay,
be.
body weight, we don't have any anything to say what is his body weight. Now this is important, okay, in knowing the outcome of the patient, but more importantly, okay, he is a diabetic patient, and diabetic patients in acute myocardial infarction, it is more difficult even to diagnose because they are known to have atypical presentation, epigastric pain, profuse sweating, no chest pain, silent infarct. Okay, they usually have more severe diffuse atherosclerosis. Okay, and in diabetic patients, the use of more potent antiplatelet like prasugrel and ticagrelol is definitely beneficial, more beneficial than clopidogrel. That has been proven in studies. And try to optimize your glucose management to below 11.1 millimole, but at the same time, you need to avoid hypoglycemia. So the comes to the question somebody asked. Okay. There is one. How frequent do we monitor sugar level? I still would monitor sugar level maybe 3 times a day or every 6 hourly initially. I would put this patient on short-acting insulin, bring down the sugar, and then maybe titrate your insulin level, your insulin according a chart, a scale, okay, so that he would not be hypoglycemic. Okay, it is not advisable to give large doses. I'm not very keen on infusion of insulin most times because this is not a diabetic emergency. Nizar?
Yeah, I think sufficient just to give subcutaneous.
Yeah.
Uh,
So TDS of 6 hourly sugar monitoring, Arifa. Okay. So long-term therapy, what kind of long-term therapy do we advise the patient? Of course, lifestyle modification and risk factors control. It is very important to advise them to stop smoking. Um, they are more likely to listen to us when they have come in with acute myocardial infarction. They're more likely to listen to us because we are doctors, which is true, more than their spouse. Okay. Counseling and adherence to medical therapy. We need not only the patient, we also need to accept that the patient will eventually need polypharmacy because we will then need to add on medication to improve his LV function. Okay. What are the medications that we need to add on to improve the LV function before he goes home if the blood pressure permits? Anyone? No? Okay. Basically, to treat him as he goes home, we need to think of ACE inhibitor, beta blockers, spironolactone, okay, and also, uh, of course, very important, a statin. Nisa,
Mhm.
how about the use of the newer hypoglycemic agents, not just for diabetes, for heart failure? Have you
Yeah,
used them?
I've used
Or
um, but particularly the SGLT2 inhibitors are probably something that I would consider in people with impaired LV function and diabetes. Even people without diabetes, they seem to be.
yes, they are already. I think FDA has approved in their guidelines.
Yeah.
And some people have added in the guidelines to add this newer hypoglycemic drugs for patients with heart failure, even if they are not diabetic. I'm not sure how it works though. Okay. Now, before I go to case two, okay, we take some questions here. They won't feel pain. Oh, yes, it is not uncommon for diabetic patients not to feel any chest pain because just like they have neuropathy to the nerve endings of their peripheries, they also have neuropathy that causes them to have silent MI and pain that are very atypical or no pain at all.
Usually, you'd expect
Us,
that in long-standing diabetics, right? If they're new diabetics, then I don't expect that they should feel pain.
yes,
Yeah.
yes. Like sometimes when they have diabetes for 20, 30 years,
Yeah. So the elderly
um,
people with long-standing diabetes are more likely to have such things.
okay. Tian Sheng said, if a patient could not specify the exact time of the onset of the chest pain, how do we gauge whether thrombolysis is still safe if we are able to transfer the patient to a PCI center within 2 hours? Now, it is unlikely that you can feel pain and you cannot tell when is the onset of the pain. That's one. Two is look at the ECG. If the ECG, the ST segment is still very high, chances it's in acute phase. Okay. If not, they will have formed Q waves. If you don't see a Q wave on the ECG, then chances are that he's still in acute phase, and within 12 hours, I would still thrombolyze the patient. There's no complication. Nizar?
If they have continuing chest pains and the ECG still shows ST elevation, you can still consider thrombolytics, and in some situation, if it's possible, even primary PCI.
Now, may I ask what's the usual dose for bolus insulin? Okay, this bolus insulin, we don't give it IV, we give it subcut. So subcutaneous. I'm not sure if you're talking about bolus IV insulin. It's not necessary in this case. Usually I will start, let's say if it's 17, maybe 8 to 12 units of humulin R, Actropid, depending on what is available in center. And then I'll watch the next few sugar level and then decide on something more definite few days. Sometimes the acute episode of, let's say, all this MI can also bring up the sugar quite easily. So any kind of form of physical stress can also cause the sugar to be increased. And then somebody said, hi, good evening, Dr. Betty. What is your opinion of a young patient? Okay, so this one we will talk about it later. We're going to discuss this case first. And no article asks, what are the other take-home medication for patients with AMI beside antihypertensive medications? So first, of course, your antiplatelet, because you have just done the angioplasty. I would definitely put him on a statin. I would put him go home with a hypoglycemic drug. The first choice is still metformin. Maybe maybe if the sugar is, the creatinine is not coming down after the blood pressure is well controlled, then you would consider form of other form of hypoglycemic drugs. Okay, and then you would definitely need patients to be on medication, not just for the hypertension, but also for the heart failure. So for the heart failure, you need the patient to be on ACE inhibitor, need the patient to be on a beta blocker, and then you need the patient to be on spironolactone. What else is there, Nizar? You would be, if possible, on a Coraline.
If the heart rate is still high with the beta blockers, yeah, I would consider Coraline.
Coraline. Have we missed out anything? I think that is about it. So, and definitely please remember statin, my favorite drug. Okay, so we go on to the next case, yeah?
Betty,
Yes?
Betty,
Yes?
my original question
Yes?
about primary angioplasty.
Yes?
So if patient present after 12 hours, why primary angio is not beneficial?
Okay. You see, as when the blood vessel, the artery is occluded, okay, I think within an hour or two, okay, 20 to 30% of the muscle would die. And after 3 hours, half of it. After 12 hours, okay, it would not be called primary PTCA anymore. Because basically, the myocardium would all be dead. So there is nothing much to rescue anymore. So there is no rush in that sense anymore. So all reperfusion therapy should be before 12 hours to save any myocardium. Does that do you get what I'm trying to say?
Yeah.
Yes.
Thank you.
Yeah. Sorry.
Thanks.
So now you get it, huh? So we go to the second case. Okay. Okay, this is a 42-year-old gentleman, and these are all young gentlemen because we are actually seeing more and younger patients. And this patient has chest pain for 1 hour, severe crushing in nature, no sweating. He has no history of diabetes or hypertension, but he is a smoker. He is active. He exercises 3 times a week. And the signs are, he's fairly comfortable, but blood pressure is low, 80/40. JVP is not raised, lungs clear, there's no murmur and there's no ankle edema. And this is the ECG. Anyone? Can anyone tell me what's the diagnosis? Or what do you actually see on this ECG? Nobody?
ST elevation,
Yes, ST elevation, very good.
V1, V2, V3,
Before
1 and
Yes,
AVM.
yes. So what is your diagnosis? Inferior and anterior septal MI, Harris said. Okay. Now this is a typical ECG, okay, of an inferior MI, okay. But what he has on top of that is actually a right-sided infarct. So, and that is why the blood pressure is low, 80/40. Now I wanted to present this case to demonstrate to you, okay, how two different, one disease, but just at the site of presentation, means an anterior MI and an inferior MI, both presenting with hypotension. I wanted to demonstrate one is because of cardiogenic shock, okay, and one is because of right-sided failure, okay. So there is a decreased right heart function which will lead to reduced LV, preload, and cardiac out. And this will cause systemic hypotension. So in this case, I want to demonstrate that in this case where you have hypotension with an inferior MI and maybe possibly a right-sided infarct, you want to give fluid challenge because this patient has no clinical signs or symptoms of heart failure. And in this patient, you would run 500 ml of crystallite or normal saline and you will find the blood pressure improving as you run fluid, okay? And then you monitor closely, okay? And in this kind of patient, treatment with nitrate may be harmful because it may bring down the blood pressure. Of course, in this case, we won't discuss further about the antiplatelet therapy, the primary PTCA, because it is the same, okay? The steps that we take is the same. But what I would like to demonstrate to you is how one case I would not give fluid challenge, and in one case I will not hesitate to give fluid challenge. Nizar, where are you?
Yep, I'm here. You need to give fluid challenge in this because it's a preload problem.
Yes. So this is a very interesting. So I want to go through again a few ECGs, okay, and a few problems in diagnosing MI, and one is actually chest pain with left bundle branch block. Nizar,
Mhm.
so In patients with chest pain, and especially if the patient just came to you and the first ECG that you see is the left bundle branch block, do you decide to treat it as an MI or not?
If it's a new left bundle branch block, yes, you would consider that as an MI actually, especially with the chest pain.
Actually, yes, especially with the chest pain. But they found that in an article that I read that only 8% chest pain with what seems to be a new left bundle branch block turn out to be AMI. But I think I would treat as an AMI and other. Okay, this is an inferior MI with posterior myocardial infarction. So typically ST elevation over the inferior lid, which is 2, 3, and AVF, and ST depression over V1 and V2. Okay. Sorry, I'm some. Sorry, can
webinar tu semua
fine.
kan. Lepas tu
Okay. So in this case, okay, this just now was inferior with posterior MI because you see an ST depression in V1, V2. And this is a true posterior MI with ST depression in V1, V2, and V3. And when we do, if we do a V7, V8, V9 lead, which is actually done by placing the leads in the left posterior axillary line at the tip of the left scapula and the left paraspinal region, we actually see an ST elevation, the lateral side, which is actually not the lateral, but it's in the posterior wall. And of course, the treatment is the same for all. Okay, antiplatelet. Okay, decisions about thrombolysis or primary PTCA. The duration should be anything less than 12 hours, and anything that can be done within 90 minutes should get anyone that can get an angioplasty done within 90 minutes should have primary PTCA. Okay, any questions? So let's see, doctor, I'm sorry, may I know when do we do the right-sided ECG? So we do the right-sided ECG when we see ST depression in the V1 to V3, and then we don't know whether it is actually an ST elevation MI or non-ST elevation MI, and we want to that is a serial MI. Okay. There is a question that Dr. Tan asked, "Hi, good evening. What is your opinion of a young female in the late 20s who have not known to have came into KK with hypercholesterol, about LDL 4.6 and a HDL of 2.3. She also has high platelet distribution. High platelet distribution, which what does that mean? But normal platelets level, normal CRP. I don't know what does high platelet distribution which means. So does it correlate to the her high LDL? She's concerned about arteriosclerosis formation and risk of MI. Nizar?
I don't think it is.
I
In the
don't think it's
case,
related.
I wouldn't categorize her as hyperlipidemic as well. If you looked at the Framingham study, the LDL, if you look at its correlation with the HDL cholesterol, when the HDL cholesterol is as high as this, 2.23, that LDL of 4.6 probably doesn't carry much risk to this lady. So she probably doesn't have an increased risk as a result of the high LDL cholesterol, actually.
Okay, I think there are two things that is in her favor. One is actually the HDL that is very high. Two is her age. Yeah, of course, three is because she's a woman who's premenopausal. So all these three actually are protective against atherosclerosis or premature atherosclerosis. Now, would I treat the 4.6 at the moment? I think that in this case, she can actually be monitored and allow lifestyle modification before we actually start her on statin. But as she ages, the HDL level is going to come down. Okay, and I think that then and if her LDL still go on at 4.6 or even higher, then definitely I would treat. But in the next few years or so, I think try um, lifestyle modification. Okay, so no article asked, can you explain how to diagnose a posterior MI based on ECG? Okay, we go back to the slides again. This is a true posterior MI. It is quite rare. Okay. And you see an ST depression over V1, V2, and V3. Okay, and you don't see any ST elevation anywhere else. Now, you may think that this could be a non-ST elevation MI or a non-Q MI, which you will not be faulted. But because you see some ST elevation here, then if you were to do this right-sided leads, okay, which you place in V7, V8, and V9, and if you see an ST elevation in these leads, then that is how you diagnose posterior MI. I hope that answers your question, Atika. Okay. Tan say I missed out on the fluid challenge part. Can I have a short recap about it? So in a lot of patients with hypotension, okay, if they are not in failure and if they present with inferior MI, always think whether you should give a fluid challenge or not. If the lungs are clear, I would give a fluid challenge because right-sided infarct is sometimes not uncommonly associated with inferior MI. Okay, and when you have a right-sided infarct, okay, let's go through the slides again. Sorry, it's a bit slow. When you have a right-sided infarct, you have decreased right heart function, which will reduce the LV preload and your cardiac output, and therefore causing systemic hypotension. So a fluid challenge in this kind of cases where there's an absence of heart failure clinically will actually bring up your blood pressure. Okay. Okay. No, Atika asked, can we explain about the component of cardiac rehabilitation? Okay, that's where it fails me. Nizar, can you explain cardiac rehab?
You basically want to reintroduce activity to the patient and take into consideration that the person has just had a myocardial infarction. So with cardiac rehab, you introduce physical activity, um, aerobic physical activity gradually. And this is usually done in stages. There is a structured sort of program that most physiotherapy department will have. So you can actually refer to the physiotherapist for cardiac rehab.
So Joanne Yeo says, so only in the absence of heart failure is fluid challenge allowed the right-sided MI. Most times, if you have no fluid in the lungs, yes, then you can try fluid challenge. But if the patient is already overloaded, it means on examination you have crepitations in the lung, I would not add any more fluid. Sometimes it can be detrimental to the patient. So in an inferior MI, that you can prove that there is possibly right ventricular MI, then I will give fluid. Okay, Tan asks, how do we confirm the diagnosis of familial hypercholesterolemia other than family history of hyperlipidemia? Okay, usually it's the LDL level of 4.9 and above with a family history or evidence of, let's say, xanthoma, plasma, and if it's a child, the LDL should be less than more than 4.5. Yes, you can do genetic testing, but it is not necessary. So I will share a slide with you, Tan. I did a I did a live chat on hypercholesterolemia, and I will share the slides. Okay, any more questions?
Betty,
Yes,
I want to ask you,
can.
can you comment on acute coronary artery spasm mimicking MI?
Okay. Sometimes people think that coronary artery spasm is actually a benign condition, but it is most times, right? We do not see acute coronary artery spasm as frequently with ECG changes as we like to. So I only have seen coronary artery spasm mostly when I'm doing an angiogram, and they can present quite badly. It means the blood pressure will drop, the heart rate may drop. Okay, the patient may even become unconscious, especially if the LV function is poor. But in the emergency setup, okay, I have not actually seen an ST elevation that turned out to be spasm. Nizar?
Yeah, I have not seen I either actually. But what's interesting is this is in traditionally it was called Prince metal angina.
Yes.
They present with ST elevation and then subsequently the ECG normalizes. And when you do an angiogram, you don't see any lesions at all, you know. More recently, I think there is something similar, but they present in something like acute myocardial infarction, and they go into heart failure as well. And when you actually do an echo on them, you see a very strange phenomenon. The heart is dilated at its base, you know, the Takotsubo sort of features. And this is also a form of what you call vasospasm as well. But what I see most often is actually vasospasm during angiograms. In some people, they are more prone to this, and there are probably cases. I have a patient that has this. She's a Japanese lady, and she gets angina pectoris as well, and she responds to calcium channel blockers, and she's had this for a long time.
But you
So,
cannot prove it, right?
sorry.
Did she have a spasm during the time when you did an angiogram?
Yes, she did.
Oh, I see.
Hmm.
Yeah,
She,
it can be very dramatic, this vasospasm, especially in diabetic patients. Okay, I had a patient recently with an LV function of 20%. I went to do an angiogram. She actually doesn't have anything. But I went to, so it nothing much, but I took the last shot and then she went to spasm. Okay. and she went to the LAD, spasm, completely occupied, blood pressure dropped, she became unconscious, had to give epinephrine, we had her on inotropes, and then she came back rapidly, especially then we have to give atropine. So it can be very, very dramatic, and you need to act very quickly, especially if the LV function is poor or when they are diabetic, because they have very poor reserve, you see. But otherwise, patient presenting with ST elevation MI in ER, chances are they're not spasm. Not that I've seen one. Faisal asked, what's your opinion on EECP therapy? Generally, because we are all interventional cardiologists and we don't see a need in EECP. I've never used it before.
There are probably two indications that I use it for. Those patients who have very poor vessels and diffuse disease, and you can't offer bypass surgery or angioplasty. ECP can reduce symptoms. It's been proven to do so. The other instance is in people with impaired LV function, with poor LV function. You can do ECP and it can actually improve their heart failure, because the ECP is just like your IABP. If you time the contraction with diastole, you get better perfusion and you get a reduction in peripheral vascular resistance. So in that situation, yes. But in preventing heart disease, in curing coronary artery disease, or in treating angina pectoris, or people with three-vessel disease, those are not indicated actually, because at all times the ECP will never improve prognosis. It's only for symptoms.
Sorry, I'm just typing but unasked about the how do we any more last few questions maybe?
Yeah, Betty, I just want to share
Yes,
something.
sure.
Some time ago, I have one patient diagnosed as acute MI, but eventually turned out to be herpes zoster on the left
Herpes.
chest.
Okay.
Left chest, you see. But the patient, when I sent the patient to the hospital, and then he came back and told me that the doctor told him he has MI and given some medication. Then he came and see me later. 1 week later, because he got blister on the left chest wall.
Okay.
So he thought that it's due to the side effect of the medication. Then I look at it, it was actually a piece, zoster, shingle.
Okay.
So I was
Let me.
wondering,
Unusual.
I was wondering what happened in the hospital. See, I didn't get any feedback from the cardiologist.
No. The doctor really treated the patient as an MI.
Yeah, he was given aspirin, given isodil, stuff like that, and was told
Okay.
that he has MI and require angioplasty later.
But an angiogram was done.
It was not done.
So it
And
wasn't.
then the patient, once I told the patient he had got herpes zoster, then he said that, can you do an ECG for me now? See whether actually I got the MI or not. So I obliged. I did an ECG. There was no Q wave.
Normal.
No Q wave.
Oh, so the doctor didn't even do an ECG?
Did an ECG, and then said
They were
that
not admitted.
admitted for 1 or 2 days lah.
Okay, so I think maybe possibly your diagnosis is correct. I have had patients coming see me with chest pain before and turned out to be herpes zoster also. Yeah, it takes a few days to actually for the eruption to start. But this is quite interesting. I think not enough investigation was done for the patient determine the diagnosis of an MI in this case.
Yes, so this was about
Yeah.
30 years ago.
Oh, 30 years ago, possibly, possibly. That's a long time ago. Okay.
So that I forever I can remember this case.
Yeah. Actually, most times, when you learn things through the patient is the best way to actually remember cases. Okay. Atika said, why we need to know axis deviation, right or left in CGs? That is very helpful most times, but sometimes it's interesting in the sense that patients with primary like respiratory disorders will probably get right axis deviation. Sometimes it's just academic mostly.
It
It doesn't.
might actually tell you that there might be bifascicular blocks actually.
That's also true. And also sometimes when you do your treatment for your heart failure, does it come in any way that the axis deviation will be helpful in your how you manage your patient?
No, but in people with left bundle branch block, yes, obviously we're looking for those people because they
But
usually
not axis deviation, right?
in some situation like say right bundle branch block with the left axis deviation, then you have your anterior fascicle block. In that situation, some of them might respond to CRTs actually. So it might help in that sense.
Okay. I think we have spoken for almost 1 hour, 20 minutes. We're going to recap. And I think at the end of this session, I hope, one, that you're comfortable in reading ECGs, knowing what is an ST elevation MI, how different an ST elevation MI from anterior to inferior to right-sided chambers, how they can present differently, even though the main problem may be chest pain. But if they have hypertension, how you should be able to then diagnose whether they need a fluid challenge, whether they need inotropes. And the take-home message is how to think while you are in ER and when the patient is admitted, CCU, and then how do you treat them long-term, prevent another episode of cardiovascular event. That is very. If we are done and there's no more questions, then I will see you guys next week with Nizar. We will do quiz. Okay. Nizar, next week quiz.
Okay.
And then after that, in December, so this month we will have 2 sessions, Nizar and I. We will see whether we can add another session for obstetric emergency. If not, next month we have another speaker. He's actually Dr. Ahmad Singh, Datuk Dr. Ahmad Singh. Do you know him personally? He's a pediatric, he was the pediatric head of department in Ipoh GH. He has just retired and he's going to speak about how to handle stress as young doctors. And then another session is how to read x-rays for fractures in neonates. So it should be quite interesting. Nisa, just join us.
Sure.
Okay, see you guys. Have a
Yeah.
nice day or whatever is left of the day. See you then. Bye.
Thank you.
Thank you, doctors.
Thank you. Bye bye.